The following podcast is part of a certified educational activity titled Building on Progress to Further Advance Care for Patients with EGFR Mutation Positive NSCLC. A look at emerging precision medicine strategies encompassing acquired resistance, treatment sequencing, and patient considerations. Access the entire activity and complete the post-test at peerview.com/MWN860. Downloadable slides and practice aids are also available.
Hello, I'm Edward Guerin, Professor of Medicine at the David Geffen School of Medicine at UCLA and Director of Thoracic Oncology there. I'm very pleased today to be joined by Dr. John Haymack, who is Professor and Chair of the Department of Thoracic and Head and Neck Medical Oncology at MD Anderson. Welcome to this educational activity focused on the latest developments in EGFR mutated lung cancer and the implications for clinical practice. So welcome, John.
Thank you, Eddie. Glad to be here and looking forward to our discussion today.
Excellent. So let's get started. So what we're planning on talking about, we're going to go through a few different sections, is we want to sort of lay the groundwork in terms of the traditional treatment of EGFR mutation positive non-small cell lung cancer. Before that, we'll sort of go through the underpinnings of the molecular testing, which of course is what identifies this population of patients in the first place. After going through molecular testing and the sort of traditional treatments that have been used, we'll talk about the recent advances, including the use of osimertinib as potentially a frontline therapy for this group of patients, as well as the recent approval for ramucirumab, and Rolatinib, along with other combinations of EGFR inhibitors and inhibitors of angiogenesis. And last, we'll move on to future directions. We'd like to start out with a case. So the first case we have is a 63-year-old woman who has never been a smoker. She's got a cough, has been losing weight, and is dyspneic. She has a chest x-ray, and that's followed up by a CT scan, and it reveals a 6-centimeter right upper lobe mass. There's also mediastinal adenopathy and evidence of several bone metastases, specifically to the thoracic spine. There had been consideration for CT-guided biopsy, but in the end, a fine needle aspirate was obtained, and it showed adenocarcinoma that was TTF1 positive. The patient has a PD-L1 result come back a couple days later, which is a typical, of course, it's an IHC test and generally comes back first. That was 25%. And the results for the next-gen sequencing were not in yet, but the patient is anxious and eager to start therapy. John, this of course comes up all the time in our patients. They've gotten a new diagnosis of metastatic lung cancer. They want to start something, and then we tell them to wait, that we need more information. Are there any triggers for you to sort of start someone on therapy right away rather than waiting for the molecular test?
Yeah, well, Eddie, you're absolutely right. In fact, I had clinic yesterday, and I had two cases that were not very different than this at all. And the first issue, as you raised, is patients are understandably incredibly anxious when this happens, and people want to be proactive, and they want to get treatment started quickly. And so sometimes the hardest thing to do is to get people to wait for results to come back. Now, in this particular case, the woman is a non-smoker, and that for me would really especially raise the importance of waiting, because the likelihood of a non-smoker having an actionable alteration like EGFR or ALK or others is around 50%, or perhaps even a little bit higher now with some of our new targeted therapies. So this would be a case where it really would be important to wait. And what I usually do is spend time explaining to people, that even though you may be anxious right now because of this diagnosis. The disease has actually been there for years. You just didn't know about it. So all that's changed now, as compared to a month from now or a month ago, is that you know about the disease now. So I really do encourage people to just wait until we get NGS data back, till we get the molecular data back. Now, are there cases where I'd get therapy going right away? There are some. So one of them is if they've got a really large tumor or something that is about to cause a lot of problems, or if there's a need palliatively to get therapy started. So for example, sometimes you'll have a tumor that is causing an SVC syndrome. It happens a little bit more with small cell than non-small cell, but sometimes it happens with non-small cell. Or if it's about to block the right main stem bronchus, or if it's causing a lot of pain because of invasion in the chest wall, and you want to get some relief. Those are all reasons why I might say, okay, let's get therapy started now instead of waiting. And I think if you don't have information about the drivers, your choices would be chemotherapy alone, and for an adenocarcinoma or a non-squamous, you could choose pemetrexed, and carboplatin would be a common choice. You could use some other platinum regimens, platinum and a taxane, but that would be, I think, the most common. One could include bevacizumab in that as well. Now, you could also consider carboplatin, pemetrexed, and pembrolizumab, the so-called Keynote 189 regimen. But I do try to hold off on immunotherapy until we get molecular testing back. So if somebody really does need to start, I try to start with just chemotherapy. Keep in mind the FDA label for the Keynote 189 regimen for pembrolizumab with chemotherapy actually states that it should be for EGFR and ALK wild-type patients. So to use that Keynote 189 regimen by the FDA label, you should have the EGFR and ALK results back. But for this patient, even though a 6-centimeter tumor is a substantial tumor in the right upper lobe, there's nothing here that's immediately eminently threatening. So I'd really encourage them to wait for NGS testing to come back.
So in this case, the patient did start therapy. They were not willing to wait for the results, and they started combination chemotherapy with pembrolizumab. And in this case that we're going through, in fact, your concerns were merited. The idea that they would in fact have a driver mutation. This patient turns out when the molecular testing does come back shortly after cycle 1 has been initiated, the tumor is EGFR mutation positive. And so I think this is a question that comes up all the time in our clinic, and these are very hard sort of second opinions when we get them, right? The patient has already started therapy, and now we're in a situation where if we had the data that we have today, we would have started something different, but now they're on something. Would you continue at that point with this patient? Would you switch them to EGFR-directed therapy? How do you approach that question?
So what I would usually do in this situation, if it's after one cycle, I usually would switch to an EGFR-based therapy. Now with the NCCN recommendations, it does say another option would be to finish some number of cycles of chemotherapy, like 4 cycles, and then do the EGFR inhibitor afterwards. And that's something I've done in some cases as well, especially if you do 2 cycles before you get the information back, or 3 cycles. I might say, let's finish 4 cycles of chemotherapy, then start the EGFR inhibitor. But generally, I would switch right to the EGFR inhibitor as soon as we got the results, just because the outcomes are so much better. And you can always use the chemotherapy later. You can go back to chemotherapy if you need to. So usually, I would switch over to an EGFR-based therapy.
Yeah, and this is a place, oftentimes, I think this is a place where you do see wide differences of opinion, and there's not a great answer. I have generally sort of gone with the idea that they're going to get chemotherapy at some point, and so once it's already been initiated, to sort of stick with it and see it through, that would be their course of chemotherapy. But I think it's sort of one of those those difficult situations you sometimes get in is particularly if you have a practice that's somewhat consultative, where you now have a person who's already sort of launched on a plan that may differ from what you would have started in the first place, and to what extent to intervene on that is always a difficult situation.
So you highlight a good point here that there are a few different approaches. So the approach you highlight is give full first-line therapy and then switch to an EGFR inhibitor later. The approach I had noted would be a possibility is just drop what you're doing and switch over to an EGFR inhibitor. And then there's a third way, and this is actually also in the NCCN recommendations as a possibility, is the sort of hybrid approach, which is get through 4 cycles of chemotherapy or so, and then use an EGFR inhibitor in the maintenance setting instead of pemetrexed maintenance or pemetrexed and pembrolizumab. There were 2 studies in the past. One was called Saturn and one was called Atlas, where Rolatinib was used in the maintenance setting after chemotherapy with very good results. In one case with bevacizumab, in one case without. Impressively long survival there in EGFR mutant patients. So I think all those are options. For me, the key consideration is I want to make sure EGFR mutant patients always get an EGFR inhibitor. So I'm a little bit nervous about putting off an EGFR inhibitor because something could happen.
So I think one thing that comes up in this case in the treatment that was chosen that I think both of us would have been cautious about was including the immunotherapy. And as you know, the patients come into us, they've seen the commercials on TV for the immunotherapy, and they tend to be pretty eager for that. How good is the data in EGFR mutation positive patients?
Yeah, well, I think there's a really important point that immunotherapy has really revolutionized the treatment of lung cancer. And it's enormously appealing to patients, and I think for good reason, that you're stimulating your own immune system to tackle the tumor. But that doesn't mean it's the right choice for everybody. And I think the data for EGFR mutant patients has generally shown that immunotherapy is not particularly effective, especially if it's used as as a single agent for patients with EGFR mutant disease. Across a range of different studies, if you look at just a single agent, if you look at just nivolumab or pembrolizumab or atezolizumab as a single agent for EGFR mutant disease, the response rates have typically been low in the single digits if you look at the objective response rates, and the median progression-free survival has typically been pretty short, usually in the range of 2 to 3 months if you've got an EGFR mutation. There was a recent analysis led by colleagues at Mass General Hospital, Justin Gaynors and others, that showed that even if you've got high PD-L1, outcomes are not that great for patients with EGFR mutations with immunotherapy. So from my perspective, immunotherapy should not be an early option, no matter what, for patients with EGFR mutation. I typically would hold it back until after EGFR inhibitors have been exhausted and chemotherapy, to be honest. I would always give patients both of those before moving to immunotherapy for patients with EGFR mutation.
Yeah, and my bias is that the poor response rate and median PFS data for EGFR mutation positive disease only tells part of the story. The promise of immunotherapy and the reason that it captures patients' imagination for very appropriate reasons is this idea of long-term durable response. And I think that there as well, when you look at it, the EGFR mutation positive patients just don't tend to be those patients with long-term durable response on immunotherapy, at least as single agent. So in some respects, we were the last holdouts in being convinced that patients with EGFR mutation should not necessarily have early PD-1 or PD-L1 inhibitors. We had some preliminary data from the Keynote-001 data that our patients who had not received a prior EGFR inhibitor, who had EGFR mutations, did better than the others. And so we actually launched a study. It was supposed to be a 25-patient study. Aaron Lisberg was the lead for the study, who, and what we were going to look at was pembrolizumab prior to EGFR inhibition, with the idea that it would be a better treatment strategy overall, even though maybe the response rate would not be as good. And we actually ended up closing the study after 11 patients. At that point, we had one excellent responder, but that one excellent responder, we actually, in follow-up testing, were able to definitively show that the patient, in fact, did not have an EGFR mutation. Most of the patients who enrolled had high PD-L1 expression. It is sort of thought that patients with EGFR mutations will not have high PD-L1 expression, but our experience is certainly there's a significant percentage, and the data would bear that out. Perhaps of particular concern is we did have one patient who, around 100 days after stopping pembrolizumab, but then the patient did subsequently move on to an EGFR inhibitor. The patient ended up having pneumonitis, which ended up being fatal. And I know, John, subsequently there's been data that has indicated that although we can't definitively determine what happened in this specific patient, but that the risk is greater after PD-1 inhibitor and EGFR inhibitor treated patients. Is that, you have data, I know, from your group, right?
Looks like, even though the numbers are pretty modest, that if you get immunotherapy shortly before starting an EGFR inhibitor like osimertinib, your risk of pneumonitis is increased. So I think that really raises the stakes, essentially, and suggests it may be really important to get your EGFR inhibitor first and keep immunotherapy for later, because there's a concern it may raise the risk of pneumonitis as well. And that's part of what goes into my thinking to not, if I don't have EGFR results back yet, to not include immunotherapy with my initial therapy until I get the mutation data back, to avoid that risk. Or, back, EGFR mutations were discovered back in 2003. ALK fusions were a couple years later, but really those were the two subgroups, EGFR and ALK, that we had for a pretty long period of time. And in recent years now, there's just been an explosion, not only of additional subgroups, but additional subgroups where we have effective therapies now. So really, from my perspective now, we've shifted to an era. Before, you could do just EGFR and ALK, and there were a number of different ways you could do that. You could do, you could do PCR-based testing for EGFR, and you could do FISH for ALK. But when you've got 7 different alterations you have to check, from my perspective, it really puts the impetus on moving towards next-generation sequencing, of getting the larger panel, because it doesn't make sense to do 7 individual tests, and you don't want to do them sequentially. That doesn't work out well for patients. You're going to run out of tissue. So really, the next-generation approaches, I think are here now for these patients, and really can, really can offer benefit for more and more patients, because you're finding a lot of these alterations.
So case 2 is a 71-year-old man diagnosed with stage 4 lung cancer 2 years ago. The patient had metastatic disease involving the liver and adrenal glands. There was a mutation in exon 21, the standard L858R mutation, and the patient was started on Rolatinib, 150 milligrams a day. And subsequently, there was a dose reduction to 100 milligrams daily due to a skin rash, and the patient achieved a partial response. But as we see, then progression occurred. In this case, it was worsening disease in the lung, and molecular testing was performed at that time and showed a T790M mutation. So I think at this point, it becomes pretty clear what we would do. I think that obviously this is where the approval for osimertinib is, and John, maybe you want to go through the timeline of sort of approvals in this space.
Well, to start with, in the very beginning, we had gefitinib as an approved agent and Rolatinib. So we call those the first generation inhibitors. Those are reversible in that they bind the receptor and then they can come out. They don't irreversibly link to the receptor. And shortly after that came afatinib. We consider afatinib to be a second generation drug typically. Those drugs were all roughly comparably effective. So the median progression-free survival, if you use those in the first-line setting, is usually about 9 to 12 or 13 months, depending on the particular study. Now, for all those drugs, resistance would emerge, and there were different resistance mechanisms, but for all those drugs, the most common one was what we call the gatekeeper mutation, or that's T790M. And that happens in a location that's very similar to the resistance mutations in other diseases, like if you've got CML and you've got the BCR-ABL oncogene, and you look at the resistance mechanism to imatinib, it's in a similar location, the most common one. And so this really became the problem, is that we were starting with first and second generation drugs. T790M was emerging, and we didn't have good treatments until the third generation drugs. And the only third generation drug that's FDA approved right now is osimertinib. These drugs are different, and osimertinib is different in that, first of all, it's got more specificity for the mutation as opposed to the wild type receptor, which means that it's got a little bit less side effects in terms of acne and rash. But more importantly, it will inhibit the T790M resistance mutation. It binds into the pocket in a different way. It binds irreversibly, and it just sort of locks itself in on that pocket of that EGFR receptor. So this really was an important advance, because we went from having no options for the patients with EGFR inhibitor resistance outside of chemotherapy, now to having a drug, osimertinib, that was actually really effective. So that was approved in the setting of T790M positive resistant disease initially. And then, as we'll talk about later, it was eventually compared in the first-line setting to the first and second generation drugs, to Rolatinib and gefitinib, and proved to be superior. Since that time, we've also had dacomitinib added. And dacomitinib is a more potent second generation drug. It shows a little better outcome than gefitinib, Rolatinib, and afatinib, but not quite as good as the third generation drugs as well. And dacomitinib is FDA approved, and that's been recently available as well, but not typically used as much as osimertinib or the first and second generation drugs.
We generally see through between exons 18 and 21. As we know, most of the mutations are deletions in exon 19 or this L858R point mutation in exon 21. But one question that comes up in clinic not infrequently there are a few mutations, the G719X, L861Q, and S768I, for which afatinib is approved based on data looking at afatinib, and there are no other agents that are approved. And one of the questions that I see often in second opinion patients is a practitioner asking whether or not to look at afatinib, which the toxicity profile is more difficult than osimertinib, where there's approval, or whether if they can get coverage for osimertinib, to go with osimertinib in that setting, even though there's really very little data there. What is your opinion on that?
Yeah, well, it's a great question. So first of all, just to mention what you've said about the different types of mutations, you can broadly think of two different types of mutations, typical or classical mutations, and then atypical mutations. And this is when a patient first presents. So the classical mutations are the two most common ones, the exon 19 deletion and the L858R. And those together comprise about 80% of patients with EGFR mutation when they first present. And then about 20% have atypical mutations. Now, atypical mutations, there's a wide variety of them. And our group has spent a lot of time digging into the dozens and dozens of different atypical mutations. But you can divide atypical mutations into usually exon 18 and exon 20. And as you mentioned, that's for the G719, the L861Q, and the S768I. The S768I is an exon 20 alteration. So for those, afatinib is approved. Now there's many others. A lot of them are exon 20 insertions. And there's a number of drugs that are being studied right now that show early promising results, but none of them are FDA approved yet. I do expect in the future we will have FDA approvals for exon 20 insertions, but right now we don't. Now going back to your question, for those three specific mutations, the G719, the L861Q, and the S768I, what would I use? Well, we've recently done a comparison, and the FDA label is for afatinib, and in fact, we found afatinib did look more effective than osimertinib. Now, osimertinib right now is just approved in the first-line setting for classical mutations, the L858R and the exon 19 deletion. And osimertinib is better tolerated. It does have a better side effect profile, but it turns out that it just doesn't happen to work as well for those three uncommon mutations that afatinib does have an FDA approval for. So I do use afatinib, even though the side effect profile is not quite as favorable as osimertinib, if you do have those atypical mutations that are on its FDA label.
So maybe I'll just spend a moment then, mechanisms of resistance, as we've sort of talked about in this case. The T790M mutation is the most common mechanism of resistance. The MET amplification is another mechanism of resistance. That's something that clearly has been looked at quite extensively in clinical trials and in several ongoing clinical trials. There are other HER family abnormalities that are seen. And then one that I think we'll address briefly in a moment is small cell transformation. The reason this is particularly important, it does become a little bit problematic in some of our algorithms for evaluating patients after progression. So in this T790M mutation positive group, there was a trial, the AURA3 trial, that compared osimertinib with chemotherapy, platinum plus pemetrexed. And this was a markedly positive study. So progression-free survival was tremendously better with osimertinib, the hazard ratio of 0.3 when compared to chemotherapy in this group of patients. And in terms of in the clinic, I've certainly found this to be an easy sell to patients. Patients, if you give them the choice between a well-tolerated oral medication and chemotherapy, generally will of course go for the oral medication. My practice has generally been to, if a patient is progressing on a first or second generation EGFR inhibitor, to look at what we sometimes call a liquid biopsy, to look at circulating tumor DNA, and if that's positive, to use that as a trigger for starting osimertinib, and that is an approved way of using these tests. And if that's negative, I've generally gotten a biopsy, and if that's negative, then I move on to chemotherapy. If it's positive, of course, go to osimertinib. But I've always had a little bit of concern in that in the original reports of osimertinib, the patients who were negative for T790M didn't do particularly well, and so if they were biopsy positive, biopsy negative, but they have sort of a liquid biopsy that's positive, I don't have full confidence, but the data in general, when you just look based on circulating DNA, does look very favorable for osimertinib in that setting. The one thing that you generally can miss when you do not get a biopsy is this small cell transformation, and that is a situation where there's certainly there's less likelihood, I think, of having T790M, although we have seen it in individual cases. But Those are patients that we generally have treated with small cell type regimens. And I think that it is something that's helpful to know. It is something that I think we certainly have the potential to miss if we don't get a tissue-based biopsy. So I don't know if your approach, John, is any different than that.
Yeah, I follow a similar approach. I think it's very reasonable to use a liquid biopsy if a patient's on a first or second generation drug to look for mechanisms of resistance. But if you don't see T790M, that doesn't mean it isn't present. In our hands, and I think when others have looked at this, liquid biopsy is good. It picks it up when it's really there in probably about 85% of cases, give or take a little bit. But there are some that you miss. And you hate to miss a T790M because osimertinib is such an effective drug in this setting. And you really don't want to deprive patients of an effective drug that can go in some cases for a year or more on a well-tolerated therapy. So I agree with you fully, Eddie. If you do the liquid biopsy and it's negative, I would get a tissue biopsy and look at with tissue-based profiling for T790M. And if it's not there, then you can have as much confidence as possible.
So let's now go on to another case. This is a 52-year-old woman who presents with dyspnea, is noted to have a pleural effusion as part of her workup, and undergoes a PET scan that shows multiple bilateral pulmonary nodules. The molecular testing is positive for EGFR exon 19, very high PD-L1 expression, 90%, and pretty good performance status 1. Do you make anything of a 90% PD-L1 expression?
So in this case, I would go with the TKI, not with immunotherapy. And here I think we have two reasonable options based on recent data. I think osimertinib, based on the Flora study, is certainly a reasonable option. I also think Rolatinib plus ramucirumab is a reasonable option. So I think either of those choices would be reasonable and appropriate on-label choices for a patient like this. Assuming she didn't have any contraindications to either drug.
Yeah, so maybe I'll go through first the data from Flora. Flora was a 650 patient study. Patients were randomized 1-to-1 to either osimertinib or erlotinib or gefitinib, and there of course are different practice patterns across the globe between gefitinib and erlotinib, and so the study made allowances for that. The primary endpoint was progression-free survival, and progression-free survival really strongly favored osimertinib over gefitinib or erlotinib in this study, and the progression-free survival was approaching 19 months in the osimertinib group, whereas it was about a little over 10 months in the group that received either gefitinib or erlotinib. And so in this patient, they did well on osimertinib as frontline therapy with a significant response. But 18 months later, repeat imaging demonstrated a new right lower lobe mass. It was 4 centimeters. Other sites looked pretty good, and a liquid biopsy was performed and revealed a p53 mutation. And so what would you do at this point in someone like this?
Yeah, well, this is challenging. So the patient has received a standard first-line agent. Osimertinib is an appropriate choice. They had a really good outcome, 18 months. That's a typical period of time, but now they have resistance. First of all, I think if the liquid biopsy shows only a p53 mutation, I think it's reasonable to get a tissue biopsy, really to see if there's another alteration in there. So I usually would get that. I also think about progression in two different ways. You can think of oligoprogression, where you only have one site that's progressing, or two sites that's progressing, or diffuse progression, systemic progression. And if it's oligoprogression, I like to think about consolidating just the one site of progressing disease as an option if they're otherwise doing well on the drug. can you radiate that one site, for example, or do some other treatment? Because we've shown recently that if you have progression on osimertinib and you do consolidation, the median PFS2, the median time for the next progression, can be as long as 12 months. So that's a really good outcome. But eventually patients do progress and need other systemic therapy. For osimertinib resistance, unfortunately, it's not like resistance to first and second generation drugs where you have one dominant mechanism and we can just go to another drug. For first and second generation resistance, we had T790M, so we could go to osimertinib in over half the cases. But for osimertinib resistance, data from our group and others has shown really a wide variety of different resistance mechanisms. So in fact, and there have been 3 or 4 different studies that have shown pretty similar results. First of all, some of the patients lose the T790M, some of them retain the T790M. If they started off with T790M when they had osimertinib. But there's some resistance mechanisms that are EGFR dependent. So in other words, they mutate the EGFR receptor. So for osimertinib, sometimes they'll develop a C797S mutation. That residue, the C797, is important because that's the residue that osimertinib covalently links to. So when that's mutated, osimertinib can't bind anymore. There's other mutations like the 792 and other sites on EGFR that can be mutated. Or alternatively, they develop a completely different pathway. So for example, it's been described that they get RET fusions and they may respond to a RET inhibitor. The most common thing they get are MET amplifications. And there's some promising data about MET inhibitors like savolitinib, tepotinib, capmatinib in that setting. And there's a whole host of other things they can get. So I think the key point is there isn't a single mechanism. There's a wide range of different mechanisms. We don't have any FDA-approved regimens for osimertinib resistance yet that are targeted therapies. So at this point, we profile them. I try to get them on clinical studies where we can. We have a number of studies for osimertinib resistance. But given that we don't have an FDA-approved targeted therapy for osimertinib resistance yet, I usually move to either chemoimmunotherapy or chemotherapy with a VEGF inhibitor, because we know EGFR mutant patients can be very sensitive to VEGF inhibitors. And in fact, the way you can combine those regimens is the Empower 150 regimen. That's one that I tend to use a lot for EGFR mutant patients. Just a reminder, the Empower 150 regimen was carboplatin, paclitaxel, atezolizumab, so the PD-L1 inhibitor, with bevacizumab, the VEGF inhibitor. So it's sort of like the kitchen sink. You're taking anti-angiogenic therapy and immunotherapy and chemotherapy and putting it all in at once. Now, it has more side effects, but actually patients are generally able to tolerate it, and we've had good outcomes on that.
Okay, so maybe we return to the case, and of course, as you mentioned, there's another regimen that would be an appropriate regimen in this setting, and now has received approval, which is ramucirumab and erlotinib. This is based on the RELAY study. This was, again, a large study in which patients were randomized. In this case, the randomization was to erlotinib with placebo or erlotinib with ramucirumab. And the primary endpoint for this study, again, was progression-free survival. And again, there was a clear improvement when the ramucirumab was added to the erlotinib, with a median progression-free survival exceeding 19 months in the arm that received both erlotinib and ramucirumab. The benefits were really quite similar across subgroups, and this includes the two main EGFR mutations that we see. So in many studies to date, there really has been considerably better outcomes with newer therapies in patients who have exon 19 deletions. In the Relay, the benefit was really quite similar whether or not patients had an exon 19 deletion or an L858R mutation. And these are, of course, as you mentioned earlier, the two common mutations that are seen in this setting. In terms of the resistance mechanisms, we don't have from this study yet a full reckoning of what all of the resistance mechanisms would be. There is some data to indicate that the rate of T790M mutations that have typically been seen with Rolatinib monotherapy would be similar in this combination therapy, at least begging the question as to whether these patients could subsequently benefit from osimertinib. But at this point in the study, really progression-free survival is what has been seen, and it's a little early to see the full data in terms of what happens at the time of progression. The adverse events were sort of what would be anticipated. These are both two sort of known quantities in terms of drugs. Rolatinib, obviously, we've used in our clinic for many years, and we're very familiar with it. Ramucirumab, of course, is also an approved agent in non-small cell lung cancer, originally based off of the REVEL study. And as angiogenesis inhibitors, you would anticipate there's an increase in hypertension. That was really the main increase in toxicity, but there were no sort of surprising new toxicities. And this data altogether in May of 2020 did lead to approval by the FDA, the US FDA, for the combination of ramucirumab and Rolatinib. And this, of course, as you mentioned, would be another potential option for this patient. But John, of course, this didn't come out of thin air. There's been a lot of preclinical and clinical data that sort of led to this first approval of this joint pathway inhibition approach.
Yeah, well, from my perspective, it's exciting to see this combination of ramucirumab and Rolatinib in the Relay regimen now available to patients now that it's FDA approved. And I think it's important to say that preclinical studies don't always predict what's going to happen in patients. We've had lots of things that have worked well in preclinical studies in mice that didn't end up panning out. This is a case where I think the preclinical studies did really tell us well in advance that EGFR mutant patients really seem to get more benefit from VEGF inhibitors than EGFR wild type patients did. If you go through the studies for this, there was the beta study that was done a number of years ago. This was a study led by Roy Herbst and colleagues. And this was the combination of Rolatinib with another VEGF inhibitor. In this case, it was bevacizumab. Bevacizumab, of course, targets the VEGF ligand, whereas ramucirumab targets the VEGF receptor 2. And in this study, overall, the study was negative. So adding bevacizumab to Rolatinib didn't benefit the overall population very much. But when they looked at the EGFR mutant subgroup, it really got a lot of benefit from bevacizumab. So this suggested that maybe EGFR mutant patients were particularly sensitive to bevacizumab. And there's now been several randomized phase 2 studies that support that patients with EGFR mutation at least get a PFS benefit from adding a VEGF inhibitor. In addition to the original beta subgroup analysis, there was a study from Japan, the J025567, that was published. And the PFS hazard ratio for that study was about 0.5, a really impressive improvement in progression-free survival in that study. Now, in the updated findings, there wasn't a significant improvement in overall survival. There was a trend, but the study wasn't powered for overall survival as well. Now, when we went back to the preclinical studies, mouse studies, for example, we had seen earlier that when tumors become resistant to an EGFR inhibitor, one of the first things that gets upregulated is VEGF. So the pathways that get turned on during resistance turn on VEGF. And so this led to the idea that if you used a combination of EGFR inhibitor with a VEGF inhibitor, that may delay the emergence of resistance. And in fact, in preclinical models, when we saw tumors become resistant, when we added a VEGF inhibitor, they actually responded extremely well. So this really suggested that the combination of targeting VEGF and EGFR may be a really potent combination, and happily, this is now supported by the clinical data, the earlier studies with bevacizumab and Rolatinib, and now the study of ramucirumab with Rolatinib. So that's to my mind, a really satisfying confirmation of the earlier preclinical work. And it argues that whatever EGFR inhibitor we're using down the road, perhaps a VEGF pathway inhibitor should be part of that regimen, because we know these tumors are so sensitive to VEGF inhibition. So that's certainly something I keep in mind for my patients, and I try to get a VEGF inhibitor as part of the regimen for my EGFR mutant patients.
Okay, and so, again, I think we talked a little bit in terms of resistance. This obviously is sort of a different case with respect to resistance, right? If you have progression on this regimen versus the frontline osimertinib regimen.
Yeah, well, that's right. So to the relay regimen, the Rolatinib and ramucirumab regimen, they got T790M at the same rate as Rolatinib alone, as you mentioned earlier. So they still do have osimertinib as an option afterwards if they do develop T790M. And we believe that's going to happen in roughly half the cases. I think in the relay study where they looked, they could detect it by circulating tumor DNA in about 40 to 45% of the cases, but there's also some that are being missed where you would do a tissue biopsy and then subsequently detect it. So this really raises an interesting question. You can start with osimertinib, and you recall from the Flora study you had about an 18.9 month progression-free survival. Or you could start with relay, which was comparable, 19.4, but then roughly half of the patients could then subsequently get osimertinib because they're going to develop T790M. And so that means that for that half of the patients, they could get an additional 10 or 12 months or even longer potentially on osimertinib. And that really delays the time until they need a chemotherapy-based regimen. So that really makes that an interesting option. So if you're thinking about first line osimertinib versus Rolatinib and ramucirumab, you've got some pluses and minuses to weigh. So for making decisions about first line therapy for patients with EGFR mutation, I like to really engage the patient and have shared decision making and lay out all the pluses and minuses of the different options. And it is good to see that we do have different options that we can discuss with them right now that are highly effective and can offer them a long time before we need to get to chemotherapy. And if you think about the pluses and minuses here, the plus side of osimertinib is it's a single oral medication, it's well tolerated, and it has good CNS activity. So particularly for patients with brain metastases, I highlight the CNS activity of the drug as being a very important feature. Now, with Rolatinib and ramucirumab, it has comparable outcomes in the first-line setting, with the median progression-free survival being, again, around 19 months. But it has the advantage that it doesn't take away the option of osimertinib, because about half of the patients will develop T790M and then can subsequently move to osimertinib, and that may go for 10 months or a year or longer on the tyrosine kinase inhibitor after that as well. So it potentially offers a longer period of time before needing to switch to chemotherapy, although it comes with the inconvenience of additional visits for an intravenous medication. albeit one that's well tolerated overall with a side effect profile that was easily managed and consistent with what we saw in earlier studies. So really, I think it's important to engage the patient in this shared decision-making, offer both options. From my perspective, I think patients who want to be more aggressive with their therapy and retain treatment options down the road may find the relay regimen to be more appealing. On the other hand, for patients that have brain metastases up front, that's one group I would strongly recommend the Flora regimen for. It's worth noting the relay study didn't include patients with brain metastases up front. Or for patients who really value the convenience of not coming in for the intravenous medication. So I think it's important to lay out those options, for patients. And it's good to have options now that we didn't have just a short while ago.
And I think just to touch on sort of future directions a little bit more, I know your group has looked at actually combining ramucirumab and osimertinib. I didn't know if you wanted to comment on that.
Yeah, well, I think for obvious reasons now, if adding a VEGF inhibitor like bevacizumab or ramucirumab improves the efficacy of Rolatinib, well, what if you add it to osimertinib, which is a better inhibitor? And so we're doing a study of osimertinib plus ramucirumab. This is a randomized phase 2 study being led by Xining Li in our group. There's a similar study going on in Japan as well. So, maybe in the future we'll have the option of adding ramucirumab to osimertinib instead of just Rolatinib. There's also an ECOG study comparing osimertinib with bevacizumab versus osimertinib alone, a study being led by Helena Yu. There's also a randomized phase 3 study going on of osimertinib plus chemotherapy up front versus osimertinib alone. And the question is, does putting those two together work better? Because there may be some cancer cells that are resistant to osimertinib but may respond, to chemotherapy. So, I think it's exciting now that our options for combining VEGF inhibitors may go beyond Rolatinib, and maybe in the future we'll have combinations that include osimertinib with the VEGF inhibitor. There's a couple of other approaches being considered as well. We're doing a study testing whether everybody treated with osimertinib should get aggressive radiation and/or surgery after the first 3 months of treatment to eliminate any residual disease. We call that LCT, or local consolidative therapy. And perhaps that should be incorporated routinely, because most of these patients have a great response and their disease is reduced to a minimum residual disease state. And so perhaps we should be targeting that. So, it's good to see the field isn't standing still, and we're now looking at a number of new approaches to make first-line therapy more effective. But it's exciting here to see that we have an additional option in addition to osimertinib now with the relay regimen, and there'll be more options to come in the future.
Absolutely. Well, I think there's been a great discussion of how both the testing and treatment landscape for EGFR mutation positive non-small cell lung cancer is evolving, and also sort of give some insights into how to translate the recent clinical trial developments into our clinical practice. So, John, thank you very much for joining us today. And for all of you listening, I hope you found the discussion to be informative and hopefully helpful to you in your practice. Thank you very much.
Yep. Thank you, Eddie. It's been a pleasure. Bye-bye.
This activity has been jointly provided by Medical Learning Institute, Incorporated, and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MWN860. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.